Hello and welcome in today's nursing webinar session. Myself Shanti, the Vice President Nursing, Yashoda Hospitals, and will be your moderator for today. Since this month we are going to observe this month as a very healthy heart month. That is the reason we have chosen the cardiovascular nursing series. And as we are going to discuss the very interesting topic on TAVR, which is transaortic valve replacement, and TAVR has emerged as a lifeline for patients in the field of evolving cardiology. So, and I think not only the nurses who are posted in the cardiac cath lab and in the ICU, I think this knowledge is required for all the nurses across. So, having said so, I think we will wait for Dr. Rajasekhar for the introduction to be finished. Let me welcome our the second co-panel expert is Dr. Kiran. Hello. And he's our cardiology consultant as our co-expert panelist. He's known for his exceptional complex coronary intervention like TAVI and TAVR. He demonstrates passionate patient care and he's a great mentor too. I welcome you, sir.
Oh, thank you. Thank you very much.
Yes. And my cordial invite to our very dedicated and very passionate learner and indeed the great teacher for all the nurses as well, none other Miss Pavithra from Hitec City, Yashoda Hospital. I welcome you, Pavithra, for the session. So I think the Dr. Sir will join us. Why don't we start the session? So you can start sharing the slide. Yes. Go to the second one. Yeah, as we know, inspiring transformation in the field of evolving cardiology. We should know how first the TAVR procedure in the world has been started. It was performed on 16th April 2002 by none other interventional cardiologist, and till date he's been recognized as a TAVR pioneer in TAVR technology. None other, Professor Alain Cribier at France. Since then, 20 years of inspiring journey, and it has been carried out by our Indian expertise like none other Dr. Rajasekhar and Dr. Kiran as well. Next slide. As you look at the prevalence of AS is nothing but aortic stenosis. According to the most trusted source of AHA, more than 20% of older Americans have aortic stenosis, and as per the NIH data, more than 60% of the patients or the people have this valvular heart disease. It's a burden in India, and we still lack the true prevalence because of this sparse data. Now over to you, Pavithra, for the rest of the session. Go with the fourth slide.
Yeah, thank you, ma'am. Good afternoon, everyone. I'm Pavithra. I'm nurse manager in Yashoda Hospital, Hitec City. Thank you, Shanti, ma'am, for giving opportunities. Let's see. Here we have two slides. One slide here, it is showing aortic stenosis. Here it is showing second slide or second image here it's showing we are inserting without removing diseased valve.
So here we would like to ask, just a minute, Pavithra, we would like to ask, sir, like, what is the quality of life after TAVR? Does TAVR improve survival of the patients?
Yes,
Dr. Kiran.
Basically, aortic stenosis is such a disease wherein if the patient develops symptoms, the survival span will be around 2 to 5 years. So they won't live more than that if they start having any symptoms of shortness of breath, any syncope. So if such symptoms occur, we need to immediately intervene. Earlier, surgical management was the only thing that was available for everyone. But considering that this disease occurs specifically for aged people, like more than 70, so you will definitely require a particular procedure wherein you will not open the heart, which is a very high risk procedure. So there are few conditions where you consider that this surgical replacement to be very high risk. So that is when Dr. Alain Cribier has found out a valve which can be replaced through the percutaneous technique without cutting open. And it has a lot of mortality benefit. You will have at least 10 years lifespan which you will not be having if it is not done once you get the symptoms in severe AS.
Over to you, Pavithra.
Yes, sir. TAVR, as we know, trans-aortic valve implantation or replacements. Let's see criteria. Patient diagnosed with severe aortic stenosis, treatable or high risk for open aortic valve replacement can refer TAVR. Like TAVR, as we know, surgical aortic valve replacement, it's a criteria, severe AS with symptomatic AS related.
So as we were discussing, that is a TAVR procedure is a very exclusive criteria for patient not going to opt for alternative like aortic valve open replacement surgery. Dr. Kiran, to you.
Yeah, the thing is, there are a few studies called partner studies. The name of the study is called partner, which has initially told that it is useful only for very severe risk patients who have to undergo surgical AVR. But now the indications are coming little closer, telling that even intermediate risk will be benefited with the TAVR when compared to TAVR. TAVR is not lower. I mean, it is non-inferior to surgical AV replacement. So definitely, if at all a patient has any high risk conditions, if the patient is frail, more than 60 years of age, so it is always advisable to give an option of TAVR. The only negative point for TAVR being the cost of it, which will soon come down in 2 years.
Over to you, Pavithra.
What happened in aortic stenosis? Stenosis, nothing but narrowing. So here in this image, we can observe aortic valve stenosis.
Dr. Rajasekhar.
Hello, sir. Just let me also welcome Rajasekhar, sir. Having said that, I'm like earlier when we were talking about the TAVR, and it is my tremendous honor as an expert panelist that Rajasekhar sir is there with us, whose competencies and skill cannot be just explained in a few span of this time. He is our certified and renowned, TAVR proctor. He's a clinical director, senior interventional cardiologist and consultant, and he does his fantastic interventions for electrophysiological studies. And he's from Hitec City, Yashoda Hospital. I welcome you, sir.
Thank you.
So, Pavithra, you can continue.
Yeah. What happened in aortic stenosis? Stenosis, nothing but narrowing. Here in this image, it's showing aortic valve stenosis. Once if stenosis happens, blood unable to flow freely from left ventricle to aorta.
So, sir, we would like to have your insight on like how can we prevent aortic stenosis, or is there any coexisting link or infection which may worsen aortic stenosis if patient has?
So aortic stenosis is one such disease which is something similar to coronary artery disease. So all the risk factors that are there for coronary artery disease like diabetes, hypertension, age, and lifestyle disorders will all, like cholesterol, high cholesterol, will all lead to calcification of aortic valve. Just like the hair grays for a aged person, even the valve calcifies. So it is just a degenerative process. So if we have to prevent it, you can delay it. You cannot stop it. So you have to control your risk factors like blood pressure, diabetes, cholesterol levels, and have a very healthy life. I think that will prevent a patient from getting aortic stenosis.
Aortic stenosis.
Let's see the causes. Congenital heart disease, bicuspid versus tricuspid abnormalities, aortic valve calcification.
So you can go to the 8th slide.
Concept of TAVR procedure. Newer and minimally invasive procedure. As we know, this procedure will attempt in cath lab only. Mostly we prefer local anesthesia. Depends patient condition, we will go for general anesthesia. It will take procedure duration is 2 to 3 hours. Depends patient condition, it may extend. Newly artificial valve is inserted without removing diseased valve.
So again, we would like to know, after having the artificial valve in the situ, is there any patients who again return and report to you with any kind of infection or any early warning problems?
No, I didn't get you. Are you asking like people develop infection post procedure?
Yes, post TAVR, if at all. Do we have any patients who comes to us like, have they developed any kind of infection, or do they have any early warning signs for which they return to you after TAVR?
Infection is not so common after TAVR because we anyways put the patient on a prophylactic antibiotic. So otherwise, usually once the procedure is done and the patient is out of hospital in 2 days, he can start walking, ambulating, and usually there are not much complications which occur within a short span from the time of TAVR.
Let's see the indication. Severe eye gradient AS with symptoms. Asymptomatic patient with severe AS and ejection fraction less than 50%.
So what are the, sir, the symptoms which we see with, high gradient AS with symptoms? What are the symptoms we see in the patients?
No, there are 3 symptoms for cardinal symptoms that are called for aortic stenosis. One is chest pain and exertion. One is giddiness and syncope. And the last one being shortness of breath and exertion. So these 3 symptoms are usually called the cardinal symptoms of aortic stenosis.
And do they wait for the procedure when they have these cardinal symptoms, and do they wait for a certain period until their symptoms subsides?
If the patient is asymptomatic, we can wait for a considerable period of time. But once the patient develops any symptoms, the maximum survival span is only from 2 to 5 years. So it is always preferable once the patient is symptomatic to get either the valve replaced by surgical methods or TAVR. So if there are any high risk features for surgical AVR, we have to always advise the patient for TAVR.
Yes.
So mostly which age group we prefer means above 60 years age group we prefer TAVR.
So we would like to hear from Dr. Rajasekhar, sir, that yes, of course, when we were just browsing through and we were just discussing the above age of 60 should undergo TAVR. What if a 40 to 50 age group have the similar symptoms of aortic stenosis? And what are the treatment options? Like, can they also undergo TAVR or TAVI, sir?
It's actually like this. The TAVR is ideal for the people for patients who are very old. So typically who are more than 70 years and who are not good candidates for surgery, who are at high risk for open surgical replacement. They are the ideal candidates for TAVR. But then above the age of 60, you can consider TAVR, though these people are in many ways fit for a surgical valve replacement. They can also be considered as an alternative modality for TAVR. But if you have a very young individual, say 40 to 50 years, you should necessarily go for a surgical aortic valve replacement. Because in the young individual, we do not recommend tissue valves. These are called bioprosthetic. We do not recommend because they get rapidly degenerated if you plant them in very young individuals. So in young individuals, we prefer plant metallic valves. These can be only implanted through surgical procedure. So younger individuals, when they go for aortic valve replacement, they get metallic valve, and surgery is the only way in which that can be implanted. In 60 to 70 years, if the patient is otherwise fit for surgery, both options are equally good and they can be offered. If more than 70, definitely TAVR is a superior option because these people are older. TAVR is a safer option for them.
Great, sir. Over to you, Pavithra.
So here in this image, we can observe we have different sites we can prefer TAVR. Here, transfemoral approach, direct aortic approach, and subclavian approach. Mostly we prefer a femoral route.
So why this TFR, transfemoral approach, is mostly used, Dr. Kiran? We wish to know.
The anatomical approach for TAVR is very easier when it is, see, in the diagram that is in front of you. If it is femoral, you can it's a straight line.
Yes.
Now, if you have to go through a subclavian, you have to take a big loop and then turn right and then get down, which is kind of difficult. So considering, and the size of the vessel, that is femoral artery, is quite big. It's around 7 mm usually. So it can take the huge sized valve into it. Whereas the other two that we have to direct aortic approach is an invasive method. You need to cut open and then get into the aorta. Whereas subclavian is usually a smaller vessel when compared to the femoral artery. So considering all the positive things for femoral, transfemoral is always a better thing when compared to other things.
Procedure checked by nurses. So when patient admitted, initial assessment done by doctor. If any existing infection, we refer to physician. So TAVR protocol, CT iodogram, we rule out any wall size, accessibility, and stenosis in the arteries. And we will do 2D co, ECG if required, chest X-ray. And CT chest, we will rule out ground glass opacity, and we will see consolidation. Prior TAVR, we will do angiogram also. We will rule out coronary stenosis and calcium scoring. And along with, we will do blood investigations, CBP, LFT, and viral markers, blood grouping, and PT-INR. So part preparation also we have to do chin to mid thigh, and we have to take high risk consent, TAC, procedure consent, and we have to do betadine bath or chlorhexidine bath 2 times. And IV cannula, we have to keep 2 cannulas. It's a preferable size, 20 gauge or 18 gauge cannula.
So any other, few vigilance which should be done by the nursing team, Dr. Kiran, you wish to convey to the nurses?
I think the vitals have to be measured by sister too, just before the procedure. I think all other things she has mentioned, right? We always do an angiogram before the procedure. I think, can you go slide? Yeah. So CT chest is done just to see if it is a high risk for surgical thing. And CT iodogram is the most important thing to be done. Nothing from the nursing part, but that's the thing that will usually decide which valve you have to implant and what access you have to go through. Otherwise, I think Pavithra has done well in this thing.
Antiplatelets and antibiotic. IV antibiotic prophylaxis before 1 hour of insertion, followed by we will give BD dose. And administered aspirin 325 and clopidogrel 300 mg at least 2 hours before procedure. Reserve blood and blood components as required, PRBC or FFP.
So these patients, when they are on antiplatelet and blood thinners, and do they also have any alarming signs where they are supposed to stop and wait for procedure, or any contraindications?
No, it is mandatory that you give antiplatelets for a patient undergoing TAVR. So it is to prevent thrombosis over the valve that is being implanted. So it's a guideline directed treatment. So we need to give it, and we take proper precautions to prevent any blood loss. Like we use ProGlide technique to prevent vascular leak, a lot of blood loss, and that's it.
So it is the instruction for all the nurses who are posted in the cardiac unit to just check these are all high risk medication, check the dosage and its prescription, how often we should give, and give without fail. If any problem, you can always escalate to your team for better improvement. Yeah, go to the next slide. Pavithra.
Intraoperative monitoring by cath lab sisters. Continuous hemodynamic and ECG arterial line pressure monitoring has to do, and we have to keep everything emergency medication ready, like atropine, adrenaline, NTC. As sedation also we have to keep ready.
Yes, you can go on.
There are very less chances patient may get atrioventricular block or left bundle branch block.
So go to the 16th slide. I think we might still require Sir's opinion. Go to the 16th slide. Yes, Sir, tell us a little bit about this, like how do we approach and how do we access the...
We make a large pore access in the femoral artery.
Yes, sir.
And we usually go with femoral artery puncture under strong guidance. And then we dilate the artery and then we put in a large sheath.
Sir, can you please come a bit close to the laptop, sir? Your voice is little low.
One is the balloon expandable valve, the other is the self-expandable valves. Depending on the duty of the patient, we decide which is the most suitable valve for the patient. Then we deploy the valve. And once we deploy the valve, we check. We do a angio and check if the valve is in position, if there is no leakage. We also do echo. We don't do TE regularly. By transthoracic echo, we check everything is fine. Then we close the artery, the hole in the artery with a ProGlide, with a closure suture device. And then we check all the hemodynamics, if everything is fine, we'll conclude the procedure.
Yes. Thank you for the update, sir. Pavithra, continue. Go to the 7th. Go for the 17th slide. Just
So there are very less chance patient may develop atrioventricular block, left bundle branch block during procedure or post procedure.
Very rarely, the rare complication happens
Yes,
in 5%
yes.
of patients. And it's persisting, some of these patients may require a permanent pacemaker.
yes.
Post-operative care by nursing. Assess the incision site, dressing site for signs of any bleeding, hematoma, infection, soakage that nurses should observe starting 1 hour every 15 minutes once. Dressing to be removed after 24 hours to 48 hours. Escalate in physician in case any early warning signs code is abnormality like heart rate, saturation. If any fluctuation, we have to inform clinician. For example, vasovagal changes. If patient will get vasovagal changes, maybe patient develop hypotension or bradycardia. That we have to observe. If patient develop vasovagal changes, immediately we have to observe procedure side. Role of dual antiplatelet. Low dose aspirin 75 mg to 150 mg daily. Clopidogrel 75 mg daily to be given to the patients. Role of single antiplatelet in case of recent coronary stenting less than 3 months duration. In case patient having any bleeding risk between 1 to 6 months followed by lifelong.
So, Dr. Kiran, do we see any patients who comes with a withdrawal of medications and to your OPD or to SIR? Yes,
Usually they do. But considering TAVR being a very costly procedure, I don't think after spending so much of money, they'll be careless. They usually continue taking the APP. In the past 2 slides, we would like to add that the nursing role is quite important in such high risk cases because we usually cannot be with the patient 24/7. So as she rightly told, vasovagal and other symptoms are to be caught very early. Hypotension, etc., should be informed immediately to the primary consultant, and they have because those things can be life-saving. So, looking at the puncture side, and other important thing is while we are doing a procedure, we usually are involved in putting the valve when doing the procedure. So there might be a slight lapse in for 5 to 10 seconds or so when you're not observing the hemodynamics. So we always want the nursing staff who is accompanying us to be very alert and keep reminding about the changes in the ECG and the blood pressure, etc. So I want you guys to train the nursing staff in these lines. Yes, sure.
Let's see advantages of TAVR. Less painful than traditional open heart surgery, shorter hospital stay, improve quality of life for patients who cannot undergo conventional TAVR.
So we would like to hear from Sir Rajasekhar sir. Is only the advantages, or do you also experience any other advantages, sir?
The biggest advantages in elderly patients who have surgery. I mean, it's a life-saving option.
Yes.
I think that's the most important advantage. Because all the other advantages you have, like shorter hospital stay, lesser complications, quicker recovery, and then better quality of life. All these things are there.
Yes. Yes.
Complication. High degree AV block requiring pacemaker implantation, acute kidney injury, maybe due to contrast, myocardial injury, access site, aortic rupture may occur, tamponade after removal of temporary valve.
So what is the most maybe these are the maybe possible complications. So what is most commonly seen post TAVR?
Most common thing is some bleeding from the axis side. That's the commonest complication. All the others are extremely rare. AV block occurs in about 5 to 10% of patients, depending on the type of the valve.
Next. So we have come to the end, and the conclusion is TAVR has become the most dominant treatment options for the cardiac patients. And why not when we have skilled and highly competent expert available under one roof? So do watch a live nursing webinar every Thursday at 3:30. And my heartfelt thank to Dr. Rajasekhar and Dr. Kiran for your precious time, and thanks to Pavithra also. And we end the session today. Thank you.